Even though there's still people flooding in, we'll keep an eye on the waiting room and keep letting people in as we go on. So welcome everyone to CMR Journal Club for August. I'm Nicole Cyberlick from the University of Michigan, and I'm organizing the journal club for today. So we have two papers today on fetal cardiac MR. So this is, an extremely complicated imaging technique, trying to image the heart of a baby that's, moving around inside the uterus. But especially with all sorts of advances in image reconstruction techniques, this has been made more and more possible. So we have two speakers today who are tackling fetal CMR at different field strengths using different techniques. Dr. Julian Ludkins and Dr. Chris McGowan, and they'll be sharing some of their brand new findings with us today. So we're going to start with Dr. Ludkins, who will be presenting the paper entitled Improving Clinical Utility of Fetal Cine CMR Using Deep Learning Super Resolution. Please go ahead, take it away.
So thank you for this nice introduction. So this is our recent paper, which was published in Circulation Cardiovascular Imaging, and it evaluates Cine CMR sequence, which was reconstructed with deep learning. And as the Cine sequence itself was low resolution Cine sequence, which was then upscaled with the deep learning resolution or reconstruction algorithm, this is often referred as super resolution reconstructions in the literature. And this was a prospective study which included fetuses with known congenital heart disease. And I will jump right into the graphical abstract. So basically, this study is a sequence comparison. So in the cohort of 42 fetuses with congenital heart disease, there were two Cine imaging stacks acquired, one standard imaging stack in an axial orientation, which we refer to as Cine normal resolution in our manuscript. And this Cine stack, it uses parallel imaging as the acceleration technique. And then we have another Cine stack in the same orientation, which uses not parallel imaging, but compressed sensing as an acceleration technique. And this data was reconstructed with two conventional neural networks, and then you get a final super resolution image, which we refer to Cine deep learning in our manuscript. And these two sequences, they were compared. And the main result is that if you use a highly accelerated image where you also have less phase encoding step, that of course you have a lower scan time. And this is a whole stack of 16 slices. And you can see that with the Cine DL, including breath hold pauses, so we do our fetal CMR scans with breath hold, that you can acquire all the data in 2 minutes. And with the standard Cine imaging, you need like almost 4 minutes for the same stack. And main results were that there was a comparable image quality. There were also comparable quantitative volumetry results. And this is also maybe the trick if you image faster in a fetus, but because we all know from our clinical routine that the biggest enemy of fetal CMR or general fetal MRI is motion. So you need a time point during your investigation where the fetus doesn't move to get like beautiful images. And if you have a faster acquisition, of course, the chance that the fetus doesn't move in between is much higher, and therefore you get reduced motion artifacts in your acquired images. And this is what we also then see in the clinical analysis. Because of the reduced motion artifacts in these Cine stacks, we were able to see 24% additional structures like ventricles, valves, and arteries. And we also had 12% additional pathological findings in our cohort when we looked specifically at the super resolution images. There are also some downsides of this deep learning reconstruction techniques because they tend to pronounce artifacts, which we also observed in our cohort. And the conclusion was that deep learning based super resolution can improve the clinical utility of fetal CMR for an accurate prenatal assessment of congenital heart disease. And I will then go back to our paper, the introduction. We all know that congenital heart disease is the most common birth defect. Yeah? It's around 1% of all of all newborns, and typically echocardiography is performed to look for congenital heart disease. But of course, also recent techniques or technical developments in CMR, we can now perform fetal CMR. And I think one big advantage was the development of an MRI-compatible Doppler sound ultra system, which we place on the abdomen of the mother, and it gives you a gating signal into the CMR system, which you can use to actually use all the normal sequences we know for adult CMR. Yeah? So all we need is a trigger point, and then we can do all the normal Cine imaging and also prospective gating, what we used to do for adult CMR, we can then do in the fetus. Yeah? So I think this is a real game changer, and this technique we also used here in this paper. But of course, if you want to image a fetus, you need a higher temporal resolution, of course, of your Cine images due to the higher heart rate. And of course, you also need a higher spatial resolution, so you have to adapt your imaging protocol. And then we can use deep learning to make or gain a better image quality. And this is what we actually did in our paper. So prospective study. So we collected 1 year for this cohort of 42 patients. And we used a 3 Tesla MRI system to do our fetal CMR scan, CM1. We scan them with a normal operate mode, so the maximum ZAR is limited to 2 watt per kilogram. We use this already mentioned Doppler ultrasound device, and we scan our patients in a left lateral position, because this is most comfortable for most women, but we also use supine position. That is what the woman prefers. And then, which is maybe interesting, are the sequence parameter of our normal resolution Cine stack, which uses parallel imaging, and the in-plane resolution was 1.7 times 1.5, and it was reconstructed to 1 times 1 square millimeter. Slice thickness 4 millimeter, was a continuous stack of 16 slices, and the average breath alteration for 1 slice for the mother was 9 seconds. Temporal resolution was 17 milliseconds. So, and these are the technical or sequence parameters for the deep learning Cine sequence we use. So as you can see over here, the main difference is that we use a higher or a lower acquired in-plane resolution of 2 times 2.2 square millimeters, and use another acceleration technique with compressed sending. All other parameters were the same between these 2 sequences. And the whole super resolution reconstruction technique was performed using 2 convolutional neural networks with a vendor provided prototype patch. And this is the reconstruction process. I think this is interesting. So we have this density weighted incoherent undersampling using compressed sensing. So this is the K-space, and you would get typically a low resolution image out of these, but this image was not analyzed in the study because the raw data was put into the deep learning reconstruction pipeline. And then there are 2 networks. There's an adaptive compressed sense net, which also have all information about signal distribution and call sensitivity profiles. But this reconstruction algorithm or CNN gives you a denoised image in comparison to the reconstruction which you would have obtained using only compressed sensing. So you get a denoised image, and then this image is an input for the second network, which is the precise image net, which removes ringing artifacts and upscales the image matrix. Yeah, and the trick is that it is not just a zero filling, yeah, where like an average value is put into the missing pixels, but it was trained on historical data, so there is actually image information put in this in this new pixels, and this gives you the final super resolution image, which was evaluated in our study. Then we did quantitative analysis of all the data. We calculated apparent SNR and apparent CMR. We also evaluated edge rise distance, and we did a volumetry and also functional analysis of our fetuses. And we also did a qualitative analysis where we rated different categories like blood pool to structure contrast, the edge definition, and different kinds of artifacts in both imaging stacks. And we also looked for additional findings. And as a result, this was we already saw this in the graphical abstract. We had a distinct reduction in acquisition times per slice and also for the whole stack. And because due to the acceleration, the mother could hold their breath for 2 slices. So this is another significant improvement. Quantitative image quality metrics were sometimes higher even for the deep learning accelerated reconstruction. And we also had a lower edge rise distance in our Cine DL images, which means that the image is sharper, which is an effect of the super resolution network. Here are the characteristics of the patient cohorts. So we had 42 patients. Mean gestational age is around the 36th week, so it's a very late scan in pregnancy. We had different CHD entities in our cohort, and I think what is interesting is that the volumetry and functional analysis, there was no difference between the two stacks. And of course, as we encountered less motion artifacts, we were able to detect 5 additional pathologies, which included ventricular septal defects, DTGA, and also a partial anomalous pulmonary venous connection. And we were also able to image one left superior vena cava superior in our cohort. I will then jump into some images. Here's an example of the edge rise distance, how it was calculated in this study. You can see the linear profile of the signal intensity, and then we measured the edge rise distance, which was lower for the Cine DL compared to the normal resolution Cine. And here's an image example of the volumetry and functional analysis, where we did not observe any differences between the two Cine stacks. And this is another figure where we can see that there's a good correlation between some quantitative metrics and that there is no actually bias in this Blend-Altman plots. And this is also a figure with some imaging examples. So here you can see the deep learning reconstructed Cine sequence and the sequence, the normal with the normal resolution. You can see the higher blood pool to myocardium contrast in this image, for example. And in this image, you can see that there is a dextrotransposition of the great arteries, which is not visible in this stack because of fetal movement. So this is how the images then typically look like if you have movement artifacts. And this is another case where we have the finding of the partial or the anomalous venous pulmonary return. Here you can see a ventricular septum defect. And here are some examples of the pronounced imaging artifacts due to the deep learning reconstruction. We can see here dark banding artifacts, and also in this picture here under F, there is a prominent backfolding artifact, and due to the denoising and also the sharpening, it gets more pronounced in the image than it would be, normally be present like in a normally reconstructed image. But this was observed more frequently, and of course these artifacts can degrade the diagnostic quality if they are in specific locations. And but something like movement artifacts, what you can see over here in phase encoding direction, this were not that often in the Cine DL reconstructed
Dr.
Cine
Lipinski,
images.
I'm
So
so
this
sorry
is
to
it.
I'm sorry
I'm
to interrupt.
finished.
I want to make sure we have some time for questions.
Yeah, I'm finished.
Okay, perfect. Thank you so much. Really amazing images in such again, a challenging population. If anyone has any questions, you can feel free to either drop them in the chat or you can unmute yourself. And I see Matthias has a question, so go ahead,
Yeah,
Matthias.
no, first of all, congratulations. This is significant because we do not necessarily have another imaging modality with a sufficiently high temporal resolution to visualize fetal abnormalities. So that's great. I wonder, so your population was relatively late, so 35, 36 weeks. When do you think one could start? Because we need at least probably 4 pixels across a wall, and then the septal wall is between 2 and 6 millimeters. So what would you recommend where the field should get interesting at which gestational age?
So we typically do it like in third trimester because then we observe the best image quality, but there are also like studies out there where they do it like in the second trimester. But this is also a question like what will be the clinical value of fetal CMR? So this is a very important question, I think. So I think decision making for parents lies much earlier in pregnancy. So their fetal CMR won't play a role, I think. So because it's the technical limitations. But I see some clinical relevance of all these techniques in late decision making. Yeah, for perinatal or postnatal management, for example. So we had several examples where we did actually image the fetus before delivery, yeah, and we use these for surgical planning because we know if after delivery they often undergo a CT scan for surgical planning, yeah, and I think this could be the role where fetal CMR will maybe play a role in the future. So perinatal and postnatal management. And therefore, I would not look into early trimesters, but I would look to improve our techniques for the late trimester.
Thank you. Thank you.
Oh, we have another question. Okay, from the images I saw, it looks like there's a lot of fetal motion correction. Do you think this could be also applied in fetal MRI overall and not just in cardiac imaging?
Sure, but we did not use motion correction in the motion correction sequence. So the deep learning images, they look a little bit artificial sometimes, yeah, but they are not motion corrected. But of course, you can, in the future, we should maybe combine motion correction techniques with deep learning reconstruction techniques, and this would be another field of research. Yeah.
So I just had a brief question. It was interesting that you said that you compared the parallel imaging standard acceleration to this very intensive processing pipeline, but you didn't compare just the normal compressed sensing reconstruction without the deep learning. So in your just experience looking at those images, like were they just so noisy and so bad that they wouldn't be useful at all? Or do you think it would be useful to do a comparison of parallel imaging versus compressed sensing without the deep learning to see how much the deep learning is actually adding to the
Yeah, of course. This is of course the drawback of the study, that the reference standard was not the sequence with the compressed sensing. This would be an interesting comparison, yeah. But we were used to look at these parallel imaging Cine sequences, and we didn't want to change that, yeah. And as we had the opportunity with this new reconstruction pipeline, we chose specifically this this study design. But of course, this is something you should look at. Yeah.
Perfect. Okay, another question. How does the higher fetal heart rate compared to adults affect the imaging parameters?
So of course the sequence was adopted to have a higher temporal resolution of 17 milliseconds, yeah, and but this was kept the same, so this was fixed, yeah. So if the fetus then had a specifically higher heart rate, yeah, so the acquisition would be actually faster, yeah. But there is also the reconstructed images per cardiac cycle were fixed to 22 milliseconds. So then the reconstructed temporal resolution, which is not the real, like required temporal resolution, would of course be interpolated and faster. Yeah.
All right, I'm glad there's so many questions, but we are going to move to our second speaker, and perhaps some of these questions are relevant as well for Dr. McGowan. So thank you again, Dr. Litkins, and
Thank you.
Dr. McGowan, you can share your screen. Perfect. All right, now we're going to move from 3T to 0.55T and take a look at fetal cardiac imaging there. Please go ahead.
Okay, can you hear me okay? Thank you for the invitation. And I'm presenting on behalf of the first author, Data Gulab, who could not make the presentation today. I just want to try and bring this up. You can see my screen, I think.
Yep, we can see and hear
Okay,
you.
great.
Yep, all good.
So this is a collaboration between Sick Kids, where I'm based in Toronto, and the group at Children's Hospital of LA and University of Southern California. And this was to explore the application of low field imaging for fetal cardiac MR, which we just heard about in the previous presentation. I think that Dr. Litkins gave a nice overview of some of the challenges of fetal MRI for cardiac imaging. Structures are small, and we, of course, face challenges with gross fetal motion and maternal respiration that can lead to increased blurring in our images. We also have to contend with fetal heart rates, as we heard in the last question. So we've done a lot of work on this applications, developing MRI methods for looking at fetal cardiac and blood flow with MRI. Meanwhile, the group at USC and Children's Hospital of LA have done a lot of technical development around accelerated imaging at low field. So we decided to join forces and see how far we could push this sort of an approach, taking their acquisition approaches for fetal cardiac MR together with some of our reconstruction approaches. So that was the goal of this work, looking at both real-time reconstructions as well as Cine reconstructions of fetal cardiac MR. So this study, some of the methodology involved 10 pregnant women that were summarized in this publication. Again, these were late gestation, 28 to 34 weeks. This was on a 0.55T scanner, but I want to note that this was a derated Magnetom Era scanner, brought down to half a T. The acquisitions used a spiral SSFP MRI acquisition. This was with a golden angle acquisition, a pseudo golden angle, repeated after 144 arms. And we collected data at a variety of spatial resolutions from 1.7 millimeters down to 1 millimeter in plane resolution. The reconstruction of these data took, it's actually summarized at the top, and maybe I'll scroll up to speak from that. So this was, as I mentioned, a spiral SSFP acquisition with golden angle. This allowed us to create a real-time reconstruction of those data using compressed sensing, which allowed us then to define regions of interest within the fetal anatomy for motion tracking, for motion correction, as well as to detect the cardiac cycle for gating. So we would motion correct the data, perform cardiac gating, and then that allowed us to bin the data for a subsequent Cine reconstruction, which then allowed us to combine data from across this real-time acquisition to generate higher signal-to-noise ratio and potentially higher quality images. So some of the examples of this are just summarized. This is a representative example. This is one frame of a real-time reconstruction in the fetus. This is at 1 millimeter in plane resolution. It's not really fair to show a single frame of a real-time acquisition, but consequently, that's why it looks quite grainy. At the right is the output of a Cine reconstruction from combining data across the cardiac cycles. And some of the data analysis is shown at the bottom. So providing a region of interest over the anatomy, you can track the motion. We do rigid motion tracking for translation, and just the solid blue and dashed blue lines represent translations in the X and Y dimensions. So you can see there's a range of about 4 millimeters in this example. And we track that motion based on the ROI's mutual information from frame to frame. And we can talk about that more in the discussion if anyone's interested. But this gives us motion, not only motion correction, but we also have motion data rejection. So there's an outlier criterion to eliminate data which doesn't have a high enough mutual information. These are some of the R-to-R intervals that are detected throughout the cardiac cycles of that acquisition. So the real-time reconstructions are reconstructed, it's mentioned up here, at about 29 milliseconds. That's an interpolated temporal resolution, which we use for motion correction and cardiac gating. The final Cine reconstructions in this case were at about 22 milliseconds. In terms of analysis of these data, because we don't have, in this case, really a gold standard to rely on, we do a lot of internal assessments. We relied on the SNR of both the blood pool as well as, in some cases, the myocardium in the real-time acquisitions and the Cine reconstructions at the different spatial resolutions. We looked at raw contrast between the blood pool and the myocardium, as well as contrast to noise ratio. And we also looked at image agnostic image metrics, this one called perception-based image quality evaluation, or PEAK, where in that case, lower values denote better image quality. We looked at the effect of acceleration by taking one of these long acquisitions. We can break it up into smaller and smaller segments and look at how increasing the amount of data we're collecting improves image quality and how it approaches perhaps the reconstruction from using all of the data, just to get a sense of how much data is required to generate a high quality image. And we also looked at reproducibility. So again, because these are golden angle acquisitions, you can break them up into these arbitrary windows. We could take one long acquisition and divide it into 2 segments and individually, sort of independently reconstruct them, and then compare them to look at normalized root mean square differences. So here's some examples from a series of 4 different fetus in this cohort. On the top are the real-time acquisitions, and on the bottom of each case are the Cine reconstructions at the different spatial resolutions from left to right. And you see the real-time reconstructions do a good job of demonstrating the raw anatomy. Although as we push to higher and higher spatial resolutions at low field, we're starting to run up perhaps against some of those signal-to-noise restrictions, which we can recover by combining data from multiple cardiac cycles. And I won't spend too much time on this figure, just in the interest of time. In terms of the data acceptance and rejection, on average, we discard about 10% of the data due to outlier rejection. The range of motion in the retained data was about 0.5 centimeter in plane displacement. I already mentioned this, that, well, maybe we'll skip ahead to look at some of the comparisons of SNR, contrast to noise ratio, and peak at each of the different resolutions between the real-time and the Cine reconstructions. As you might expect, the SNRs were improved, and this is the case for the Cine reconstructions versus the real-time. And unsurprisingly, you see a boost in the SNR on average across all of these different spatial resolutions, but with, of course, a consistent decrease in SNR as you go to higher spatial resolution. And that held true for the contrast to noise ratio as well. We also saw a improvement in this agnostic image quality measure, which puts this in the category of about of a good image quality, even at high 1 millimeter spatial resolution. These show examples of how that, as you increase the amount of data that's being used to reconstruct the image, here you see the acquisition times ranging from 1.4 seconds up to 14.2 seconds. And you can see here, by the time you reach perhaps about 7 seconds in the acquisition, you're starting to reach a steady comparison with the total scan. So this gives us a sense of what the minimum data collection time might be for generating a high quality image at these spatial resolutions. And then here, this is now taking a long acquisition and breaking it up into 2 segments. And you can see there's qualitatively good consistency between we'll call it scan 1 and scan 2 across the different spatial resolutions. Here you can start to see some undersampling artifact and some perhaps clustering in the residual data, which didn't appear in the reference when you combine them. And that just goes to show that when you have better coverage of K-space, that it reduces some of those artifacts. So I'll conclude by saying we've demonstrated the utility of combining data from a real-time acquisition to generate higher quality images, which might allow you to push the spatial resolution at low field. We think that this is an interesting avenue, like others are pursuing, using the wide bore systems, which are quieter and maybe more comforting for pregnant subjects, which can be challenges in a smaller bore system. Despite the success of this, there are a number of challenges. This was a derated 1.5 T scanner, so it had high performance gradients. So that's something that can be investigated. And in fact, a number of groups are already looking at this and showing good comparisons between commercial low field scanners and what we've shown here. Our reconstruction times were offline for the Cine reconstructions and time consuming. And so you can imagine hardware improvements will aid this, but also we identified machine learning as we heard in the previous talk. So this is something that I think others will push forward. At the time, we didn't have fully automated region of interest designations for motion correction and gating. And that's something that, again, we're looking at deep learning segmentation and have this working internally. So I will stop there.
Great, thank you so much again for showing us these amazing images at low field. So we have a question that might apply to both of our speakers, and the question is it possible to do PCM, I'm assuming that means phase contrast imaging?
Shall I start?
Go for
I guess.
it.
Yeah, so we actually started our work in fetal MR with an interest in flow because of the challenges with quantitative flow with ultrasound. So it's actually possible to do it with these approaches or with the Doppler gating approach using conventional phase contrast. And we've done work in 4D flow and others are using very aggressive conventional 4D flow acquisitions or experimental 4D flow acquisitions to look at this in the fetal circulation as well.
Perfect. I had a question about the low field system. Excuse me. So, I understand like on the commercial systems, there might be a wider bore, which is a little bit more comfortable. Are there other intrinsic advantages to operating at 0.55 T, or is it simply just the additional space and maybe the quietness if it's possible to run these acquisitions on the lower gradients?
Yeah, that the lower field really appealed to us because the group at USC with Krishna Nayak has such a long history with developing spirals and working with Ye Tian as well, doing some of that reconstruction. They already had a working acquisition with very low off resonance artifact at low field. So this was really a good marriage of real-time acquisition, which it's sort of for free, taking that real-time acquisition, which is more interactive and similar to an ultrasound, prenatal ultrasound scan, lends itself to feeding it into a reconstruction pipeline after the fact with very high quality spiral acquisitions. So you don't have the same air-water interfaces that you do necessarily in adult cardiac
Right,
as
yeah.
well. So it lends itself really nice application.
Are there any other questions from the audience? I know we're a little bit over time. All right, if not, then we are going to wrap it up. I'm going to hand over to Matthias to introduce our topic for next month.
So thank you
You're
very
muted. Yeah,
much,
there you go.
and I want to thank the also from my end the fantastic and interesting presentations today. So next week we'll go towards really more application, not so much technology. And I found two papers that are basically back to back from the same group, but both extremely interesting. And it's about athlete's heart and ways of CMR to better understand the physiology of what happens in athletes. And this is about elite athletes on one side and see what we can learn from T1 mapping. And then how the female heart responds differently to basically high performance sports. So extreme phenotypes of female athletes. And thanks to Dr. Dames and Dr. Van Diepen to be available for presenting there. So I'm looking forward to that and hope to see you there on September 3rd at the usual time. Thank you.
Awesome. Thank you so much. There is one additional question, and I'm going to ask the question asker to reach out directly to Dr. McGowan in the interest of time. But I also want to put in a shameless plug for SCMR. I believe the deadline is coming up at the end of August if you're submitting abstracts. So we will not meet before abstract submissions are due. So if you are thinking about traveling to Brazil for SCMR, pay attention to the abstract deadline. With that, thank you again to our speakers. Thank you everyone for joining us, and we'll see you next month.
Bye. Thank you.
Bye.
Thank you.